From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Greetings and welcome to our listeners around the world. You're listening to JAMA Ophthalmology Author Interviews, and thank you so much for joining us. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology, and today we're going to look at gender differences in case volume among ophthalmology resident graduates. This cohort study was assessing whether ophthalmology resident trainees who are underrepresented in medicine reported equivalent surgical experiences to trainees who were not underrepresented in medicine within the same cohort. And joining us is the first author of that investigation, Dr. Susan Culican. Dr. Culican is a professor of ophthalmology and the Senior Associate Dean of Graduate Medical Education at the University of Minnesota Medical School in Minneapolis. Dr. Culican, thank you so much for joining us today.
Thanks, Neil. I really appreciate the opportunity to talk about this study. And it was conducted as a collaboration between our group and the Accreditation Council for Graduate Medical Education, of which I serve as a volunteer member on the Ophthalmology Residency Review Committee.
Well, thank you so much again. Maybe we could start with why your group did this investigation in the first place. Wasn't there an article in 2019 in JAMA Ophthalmology that reported gender differences in surgical volume among ophthalmology residents? What did that study show?
That study was a study conducted by 24 different ophthalmology residency programs who contributed their own surgical case log data to look at whether there was a disparity between female and male residents in surgical education around specifically cataract surgical volume and total surgical volume. And indeed, that study did show that there were significant reductions in the volume of surgeries that women performed compared to men that could not be explained by things like parental leave. The issue with that study was that it was a subset of the residency programs in the United States and represented about 20% of the programs in the country. In order to determine whether the results of that study were a sampling bias or whether it was representative of the population, we aimed to look at all resident graduates across the United States and test the same hypothesis.
So approximately how many ophthalmology residents graduate each year in the U.S.?
It has varied over the course of our study. We looked at 10 years worth of data, graduates from the years 2014 to 2023, and it ranged early on around 450 graduates a year to up over 500 a year by the end of the study. There was approximately a 10% increase in the number of graduates over that 10-year frame.
So you're looking at more than 5 times the number that were looked at in that initial survey in 2019. Is that right?
Correct.
So how did you determine in the first place how many ophthalmic surgeries these residents did across the United States? Did you call them up? Did you have some information on that? How do you know how many surgeries the residents are doing?
That's a really good question. The Accreditation Council for Graduate Medical Education, I'll refer to them as ACGME, keeps something called a surgical case log. And the surgical case logs are managed through the ACGME for the purposes of program accreditation. In general, we want to make sure that resident trainees have enough exposure to surgical procedures to gain competency before they graduate. And the Accreditation Council monitors this. So every resident across the country, whether in ophthalmology or any other surgical training program, will submit to the ACGME a tally of how many procedures they've done over the course of their training. And this is maintained by the ACGME in their case log system. And we were able to pull that data to analyze it to see if there were differences between different groups of learners.
Okay, I see. So I know when the first article came out in 2019, Dr. Julia Haller, who is a chair at Wills Eye Hospital, wrote an invited commentary on that. And she said, oh, well, that's no good. But I looked at my program. I'm sure we're doing just fine. And she said to her horrors, she found that the women were doing less surgery than men. What did you find in this study then when you looked at all ophthalmology graduates from residency programs? What were the results from this survey?
The results were the same. So it turned out that that group of 20% really was representative of the total. So we did find that women did approximately 5% fewer cataract surgeries than men. And we also found that their total volume of surgical procedures was less than men.
So one question that people have when they hear this information, because this is not only ophthalmology surgery programs, it's other surgical programs as well, is they look at that magnitude of the difference and they ask, okay, it's not the same. Does that 5% mean anything? What's the clinical relevance when you go out into the community to practice and start doing cataract surgeries? Or what's the relevance if you're going to a university-based practice?
Yeah, it's a good question. And I don't think that my paper can answer that, but it's certainly something that we want to look at in the future. What we can say is there's ample evidence in the literature that when studies have explicitly looked at surgical skill in addition to surgical volume, there seems to be no difference in ability and competency between the women and men that are graduating. And in addition, we know that in the ACGME system, there are these things called minimum requirements. The minimum requirements are set by each residency review committee independently. A collection of experts in the field agree upon a minimum number of surgeries that residents have to do to be able to graduate. And all of our residents in all of our groups met or exceeded the minimum requirements across all of the surgical categories that we explored. So there does not seem to be a competency impact based on these findings, but it presents itself as a disparity that needs to be further investigated so that we can understand what does it mean.
And for these differences that you saw for women and men, this overall difference of 5% fewer cataract surgeries that were performed, was that 5% across the nation? Were there certain factors? Some people had 10% more in women and others had 25% less in women. Did you have any granular data like that?
No. So that's a very good question, and that will be the follow-up study. So just as this study is the follow-up of the paper that was published in JAMA Ophthalmology in 2019, I anticipate that will be the next question that we seek to ask. The data that we pulled from ACGME did not have program level information in it. It was simply the race and gender and the surgical volume for every single graduate. It did not include granular information about where they trained. That would be a different study that would look at the explanation for the finding we had. This was really meant to test the hypothesis that the paper that was published in 2019 is either reflective of the population or not.
So you also looked at other groups that are underrepresented in medicine besides just women and men. What were those groups and what did you find?
Right. We looked at the group that is underrepresented in medicine. So we compared any graduates that self-declared underrepresented in medicine status compared to the group that was not underrepresented. And not underrepresented in this particular case included white or Asian self-identifying trainees. And what we looked at there is other surgical subspecialties have indicated that there are disparities not just between men and women, but between underrepresented and non-underrepresented in medicine. So we tested the same hypothesis for cataract surgery and total volume for those underrepresented in medicine. And interestingly, we found that there was no difference in cataract surgical volume between underrepresented and non-underrepresented, but that there was a decrease in the number of total surgical procedures that those underrepresented in medicine completed.
So did you have enough underrepresented in medicine that you could look at it by underrepresented in medicine and women versus underrepresented in medicine and men?
We did not. The sample size was so small that we were unable to do that comparison. So it is possible that the fact that there are more women in the underrepresented group means that the disparity we're seeing is really more attributable to the gender differences than it is to the underrepresented status.
All the more reason to keep looking into this. So tell me, are there other confounding factors that might have accounted for this unrelated to the actual surgical volume? For example, do women write down all the surgeries they do, or maybe they underreport and say, oh, I'm not going to include that. That's really not relevant. Where the men maybe overreport and say, yep, I put some artificial tears on the eye before the surgery. I participated in that surgery. Of course, I'm giving extreme examples, but my question still is, could there be other confounding factors that might relate to the results that you found?
That's the major one. All of these case log data are from self-reported experience from the learners. So we did peruse the literature to see if there was anything that would support men over-reporting or women under-reporting on a systemic basis, and did not find anything to support that hypothesis. It seems that there are good doobies who do a good job logging their cases, and then the needs to be nagged all the time, equally represented across female and male trainees.
So let's say the reports that they have are indeed representative of the actual surgeries that they're doing. Your group must have thought about why this has occurred. And I know your study wasn't designed to do that, but have you begun to hypothesize what reasons might account for seeing a difference? You would think with hundreds, if not thousands of graduates, if all else is equal, it should come out the same, yet it wasn't equal. You have this 5% disparity overall of fewer surgeries in women than men.
Yeah, that is where the meat of the discussion goes, is what can possibly explain this if it is actually true and it's not an artifact of the way that the data was collected. And there are a number of publications that explore some of these reasons. The one that comes most to mind for me is something related to gender concordance or gender discordance in terms of behavior. And in the operating theater, which is a high stress, high energy location, when men advocate for themselves and want to jump in and be a big part of this case, they're rewarded for that behavior because they're supposed to be breadwinners and leaders and jump in and push things forward and move the envelope. When women advocate for themselves in similar situations, that is gender discordant behavior. Women are supposed to be subservient, they're supposed to follow and not lead. And when they act in a way to self-promote, they're actually punished for that behavior because it is not socially acceptable. And in the case of surgical learning in particular, not surgical performance, but rather as a learner, there's a complex dynamic between the attending surgeon who has to grant autonomy to the trainee to be able to conduct the procedure, as well as to the trainee who has to advocate for themselves to be able to demonstrate their competence in a way that is believable to the attending such that they can do more in the learning space. And this dance of gender concordance and self-advocacy can create quite a conundrum in a learning environment. And I find it a very interesting hypothesis of which to view these data through that lens, as it makes a lot of sense given the environment in surgical education where there's both a granting of autonomy and a stepping up at self-advocacy.
Well, I certainly look forward to hearing more from your group and others investigating this. I've been thinking about it for 43 years when I started my residency, and it looks like we still have a lot to do. So thank you so much for doing this today.
Thank you. Thanks for the invitation. Appreciate it.
I'm Neil Bressler, and I've been speaking with Dr. Susan Culican about gender differences in case volume among ophthalmology resident graduates. You can find a link to the article in this episode's description. This episode was produced by Shelley Steffens at the JAMA Network. You can find a link to the manuscript in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcast. Thanks, everyone, for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.